بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, this is the last part of the topic of anorectal lesions, and we have discussed the rectal anatomy and pathology in 2 lectures, and we discussed the first part of the anal pathology in the previous lecture, and now we will continue with the last part of the anal pathology. Actually, we have discussed the anatomy and the inflammatory conditions. We said some words about the fissures, the diagnosis of the different types of anal fistulae, anal abscesses, polyps, and bilonidal sinus disease. Then we are left with benign neoplasm, squamous cell neoplasms, and other neoplastic lesions. This is the list we would like to discuss. And finally, we have some words about hemorrhoids and what is known as the solitary rectal ulcer syndrome. Starting by the benign lesions, this is one of the common lesions, which is known as the fibroepithelial polyp. This is a benign lesion and is seen in about 45% of patients undergoing proctoscopic examination. It is considered an acquired lesion arising from the columns of Morgagni at the dentate line. The polyps may appear clinically as the hemorrhoids. They lack the thick wall veins of hemorrhoids with no evidence of hemorrhage or organizing thrombi. The lesions are usually small in size and they are commonly asymptomatic. The size is from about 4 mm to up to 2 cm, while lesions above 3 cm in size should be assessed for the possibility of malignancy. Some of the lesion symptoms may include pruritus, foreign body sensation, mucus discharge, and the sense of incomplete evacuation. This is the gross appearance of the polyp. And this is what is considered a giant polyp, which is about 15 by 12 centimeter in diameter. The polyp has a smooth surface with lobulated outline and a wide pedicle attaching it to the anal canal wall. Actually, if you look to this CT scan, and you can see that there is an intraluminal relatively hypodense polypoidal lesion within the distal part of the rectum and the proximal part of the anal canal. But you may put some for the differential diagnosis in this case, but many of the lesions that we will discuss in this part occurring in the anal area you cannot reach the diagnosis unless you have a guided biopsy. The fibroepithelial polyp is distinguished from the adenomatous polyps that may occur in the colon or even in the anal canal. The mucosa is white, and this is one of the differentiating points that the radiologist cannot see by himself in most of instances. The surface or the surface of the polyp is white, compared to the reddish appearance of the adenomatous polyp. The stalk of fibroepithelial polyp originates from the squamous side of the dentate line, meaning that it arises below the level of the dentate line. And closure of the biopsy forceps on the fibroepithelial polyp may result in pain, or usually results in pain. Biopsy is always taken to assess the origin of the lesion and to exclude the possibility of an underlying malignancy. If you have barium study or CT, then the possibility of detection of this polyp on CT or on barium studies is uncommon. That's why the polyps are identified clinically and even felt by the patient and visualized by the clinician. Then the polyp, if it is large enough, it can prolapse in the rectum, and the differential diagnosis may include internal hemorrhoids, rectal polyp, anal carcinoma, or submucosal anal tumor. And this is another example of fibroepithelial polyp by contrast enhanced CT scan, by rectal ultrasound, and by endoscopic appearance. Then one of the important issues is the white mucosal surface as seen by endoscope, and the heterogeneous echogenicity of the polyp by ultrasound. Then this is the gross specimen, and you can also appreciate the white surface of the polyp. Then we came to the granular cell tumor, and this tumor belongs to the neurogenic tumors arising in this area, and it originates from the Schwann cells based on immunohistochemical assessment. And this granular cell tumor is common in the head and the neck, and in the skin of the chest and upper limbs. The perianal location is rare, and this lesion is asymptomatic, incidentally discovered, may be mistaken for an abscess, and the clinical symptoms include discomfort and sometimes bleeding. Complete removal of the tumor is diagnostic and therapeutic. The granular cell tumor may occur in the anal canal and may occur in the rectum, and at that time you cannot discriminate this lesion from a rectal tumor or from a rectal carcinoma. Then this patient is injected by ultrasound gel in the rectum to distend the rectum and to assess better visualization of the lesion, which shows low signal intensity and this T2 weighted images. And this is the endoscopic appearance of the tumor, which was suspected by endoscopy to represent rectal cancer, but the biopsy resulted in a granular cell tumor. Then this is another example. This is T2 weighted image, and you see a very small lesion adjacent to the anal canal, and this lesion enhances strongly after injection of contrast, and this is one of the criteria of this granular cell tumor, and this the appearance of the lesion in the sagittal image. Actually, the granular cell tumor may present by a benign mass, or sometimes it may present as a malignant lesion, as you can see in this particular case, where you see an infiltrative mass involving the anal area, extending into the pelvic floor, as well as infiltrating the right ischial rectal fossa. Actually, you cannot say from this MRI that you are dealing with a granular cell tumor, but you may suggest some of the diagnostic possibilities like lymphoma, for example, and infiltrative other kind of tumors. If the patient is young, for example, you may suspect rhabdomyosarcoma and so on. But you will reach the diagnosis by the biopsy, and these are the appearance of the tumor by CT and by MRI. Then we came to another lesion, which is the myofibroma. And this lesion is almost similar to the neurofibroma. Sometimes it can be solitary and can present in a generalized form, represented as or known as the myofibromatosis. And this commonly occur in the skin and subcutaneous tissues of the head and the neck, and it is rare in the gastrointestinal tract. 40% of patients with myofibromatosis may have visceral lesions. The pancreas, liver, testes, ovary, GI, and the brain are some of the reported sites. The lesion has almost let us say a characteristic signal which is isointense in the T1, hypointense in the T2 because of the fibrous component, and if you inject the lesion with contrast, it will enhance significantly. And sometimes because of its similarity to the neurofibroma, it may show the characteristic target sign, which is one of the diagnostic criteria of the neurogenic tumors. Then this is an example of a lesion. This is T1 fat set. You see a lesion which is intimately related to the right side of the anal canal. And this is the T2 weighted image, and you can see the darkness of the tumor. And here is a coronal post contrast, and you see the enhancement of the lesion. Then we came to another benign lesion, which is leiomyoma. And you know that leiomyoma is common in the GI, especially in the esophagus and the rectum. But leiomyoma of the anal canal is considered very rare. The tumor originates from the muscularis propria, and the lesions are more commonly seen in males with a peak of incidence in the elderly life. The patients may be asymptomatic or present by pain, perineal mass, and bleeding. Smaller leiomyomas are confined to the anal canal, while the larger one will protrude through the anal canal into the perineal region. Leiomyoma have a low signal in the T1 and intermediate signal in the T2 weighted image, and they show some homogeneous contrast enhancement. But leiomyosarcomas will show heterogeneous signal in both T1 and T2, and they will show heterogeneous post-contrast enhancement. This is an example. This patient presented by perianal purulent discharge. On examination, an orifice of perianal fistula located 2 centimeters far from the anal verge. And also there was a mass measuring about 3 centimeters in diameter. And the MRI showed the mass, and also you can see the fistula tract. Both are located in the intersphincteric plane. And this is another example of leiomyoma, where you see an intermediate signal lesion in the T1 and a low signal lesion in the T2, and also this is a coronal image, and you see the low signal appearance. This is a T1 fat set before contrast injection, and this is after contrast injection, and you can see the intense homogeneous post-contrast enhancement. Then we came to another lesion, which is the lymphangioma or the cystic hygroma, and most of these lesions are located in the head and the neck region, while intra-abdominal lymphangioma is seen in about 5% of all lymphatic malformations, and the mesentery is usually the most common site, but other areas can be involved. Lymphangioma is asymptomatic unless it is large. It will compress the adjacent structures. If there are complications, they include intracystic hemorrhage or cyst rupture or secondary infection. Lymphangioma on MRI will appear as multilocular cystic lesion containing simple fluid, but lymphangiomas containing chylous fluid or those that are infected will show mixed signal intensity. If you inject contrast material, there is no enhancement except for the internal septations. And this is an example of lymphangioma infiltrating the perineum. And you see multiple locular lesions of high signal in the T2 weighted image and low signal in the T1 weighted image. This image is obtained after contrast injection, and you see faint enhancement of the internal septations. Then we came to the neurofibroma, and the neurofibroma, as you know, may be solitary, multiple, or plexiform. And the group of neural lesions include neurofibroma, ganglioneuroma, schwannoma, perineuroma, and the granular cell tumor that has been mentioned before. You know that we have two types of neurofibromatosis. The neurofibromatosis type 1, which is known also as von Recklinghausen disease, or peripheral type. The neurofibromatosis type 2, or the central type, or the bilateral acoustic neurofibromatosis type. Only in about 25% of the patients with neurofibromatosis type 1 may have GI involvement, usually of the stomach or the small bowel. Intestinal neurofibroma involves the submucosa and may extend to the serosa, while neurofibromas of the colon are extremely rare, and they occur in association with neurofibromatosis type 1, and this is the age incidence. And you know that the risk of malignancy is increased in the presence of neurofibromatosis type 1 or in the plexiform type. And this is an example of plexiform neurofibroma showing low signal in the T1, high signal in the axial and the coronal T2 weighted images with the classic appearance of target sign, a central core of fibrous tissue, and a peripheral part of myxomatous tissue. Another example of a neurofibromatosis type 1 infiltrating the pelvis and compressing the rectum, and another one is seen in the gluteal region, and you can easily appreciate the target sign. A third case of neurofibromatosis infiltrating the subcutaneous tissue, intrasacral canal, the gluteal area, and the pelvis, and also you can see the target sign in many of the lesions. And this is a neurofibromatosis by CT, where you got bulky, lobulated soft tissue masses of relative hypodensity and infiltrating most of the pelvis, extending into the gluteal regions, and some of the neurofibromas are seen adjacent to the femoral vessels. Then we came to the malignant lesions, and starting by this, let us say the skin pathology, and in anal intraepithelial neoplasia, which is considered the precursor for anal squamous cell carcinoma. This lesion is seen in particular in immune suppressed patients and may be detected incidentally during the examination of this area for other complaints. The lesion will appear, as you can see here, as an eczematous, scaly, white, or pigmented lesion with or without fissures. The bad signs are induration or ulcerations, which will indicate the poor prognosis. Anal intraepithelial neoplasia may be of low grade or high grade, and they are treated with local ablation or surgery, and they are associated with human papilloma virus, and then in such patients, the human papilloma virus may benefit from the vaccines against this virus. Then we came to one of the important issues, which is the anal cancer. And the anal cancer is mostly of the squamous cell type, and some of the lesions may be of the adenocarcinoma type, and 5% are other rare tumors like melanoma, metastasis, guest tumor, and so on. Then anal cancer is uncommon, accounting for less than 2% of large bowel malignancies. The age incidence between 45 and 75 years of age, and may have a slight female predilection. About 45% of patients present by rectal bleeding. About 30% may have pain. Then you remember the best method for evaluation of the anal canal by MRI is to have the sections in orthogonal plane, meaning that relevant to the direction of the anal canal. And you got the axial images perpendicular to the direction of the anal canal, and you got the coronal images parallel to the direction of the anal canal. Then this technique is very good for assessment of perianal fistula and also in assessment of the rest of the anal pathology. Then you have T2 weighted axial images, and you have coronal T1 and T2 axial images, and you have coronal T1 and T2 weighted images, and it is better to have a relatively small field of view in order to obtain high resolution images. Sometimes we may use the diffusion weighted images for evaluation of the anal cancer, and many of the literature do not favor the use of contrast material in evaluation of anal tumors, since they are convinced that contrast enhanced images are unlikely to give additional information, and this is relatively right, and you'll see this in the coming cases. The staging of the anal cancer is much easier than that of the rectal cancer, and it depends mainly on the size of the tumor at the greatest dimension. If the tumor size is 2 centimeter or less, and this is T1, between 2 and 5 centimeter, and this is T2, more than 5 centimeter, and this is T3, tumor of any size but invading the adjacent organs is T4. Then the nodal criteria are relatively established for the rectal cancer, but they are not yet established for the anal cancer. And the reliability is on the MRI features of the affected nodes, including the irregular contour, the speculated margin, and the heterogeneity or the presence of internal necrosis. According to the literature, the PET-CT may have a greater sensitivity than MRI and CT in detection of pathologic nodes. And these are the staging of nodal involvement in the cases of anal cancer. Then for M staging, M0 means no distant metastasis. M1 means the presence of distant metastasis. And the involvement of the para-aortic lymph nodes or more distant lymph nodes is considered also an M1 disease. As I have mentioned before, that the composition of the anal canal has two different parts separated by the dentate line, and each part has its own blood supply, venous drainage, and lymphatic drainage. Then tumors above the dentate line will be drained to the mesorectal and internal iliac lymph nodes. Tumors below the dentate line will be drained to the external iliac, inguinal, and deep inguinal lymph nodes. And this is an example of an anal cancer totally infiltrating the circumference of the anal canal in the axial images, and in the coronal and the sagittal images, and you can see that the tumor has involved the whole length of the anal canal and may progress into the distal rectum. As you remember that this is the level of the levator ani muscle from the previous anatomy discussion. Then this is the diffusion weighted image, which sometimes is helpful, especially in the detection of involved lymph nodes in the perianal area. And this is another case of an anal cancer infiltrating the internal anal sphincter, but the external anal sphincter is not yet infiltrated, as you can see in this example. And this is an anal cancer that has been treated, and the follow-up after therapy 3 months after therapy showed significant regression of the tumor with residual fibrotic band at the site of the lesion. And this is another example of anal carcinoma that has been treated by irradiation for 8 weeks. Then the follow-up after 8 weeks showed significant improvement on chemoradiotherapy, but at the time of surgery, and you know that these tumors are downstaged by preoperative chemo irradiation, then they removed to enhance the the outcome of surgery. And at the time of surgery, the tumor has grown up, and this was confirmed as local tumor recurrence. Then this is a problem where you can see that there is a malignant lesion involving the anal canal and the distal rectum. And the question is this is a rectal tumor that has invaded the anal canal or an anal tumor that has invaded the rectum? And according to the literature, they said that this will depend on the histopathology. If the tumor is a squamous cell, it is considered of anal origin. If the tumor adenocarcinoma, it will be considered as a of rectal origin. Then you will say that I have mentioned that about 10% of the anal tumors are mucinous adenocarcinoma. But I will say after that that most of these lesions are tumors coming from the rectum invading the anal canal. Then we came to one of the lesions that is reported in the literature to be a rare type. But actually, in my opinion, if you see in the literature that a lesion is rare or extremely rare. And if you tried to search for this lesion on the internet and you got a lot of cases, then you may have some in your self that this lesion, if it is rare, the numerous cases shown in the internet may indicate that this tumor can be seen in the clinical practice, not that frequently, but infrequently. And it is rare, of course. I didn't see any case in my life uh, with this diagnosis that is aggressive angiomyxoma. This tumor is particularly seen in women in the young age or the reproductive age between the fourth and fifth decades of life. If it is seen in women, it will involve the vulva and vagina, the perianal area, and the perineum. If it is seen in men, it will involve the inguinal-scrotal region. This tumor spread between the organs. It does not invade the organs. And these tumors are usually manifesting as a painless mass or due to the local pressure because they are, in most of the cases, they are sizable. And the tumor has a characteristic swirled appearance, like this appearance, or as you can see, there is a big lesion infiltrating the pelvis and the anal area. And in the T2 weighted image, you can see this striated or swirled appearance. And this appearance, according to the literature, is not seen by any of the lesions occurring in this area except for the aggressive angiomyxoma. Then the aggressive angiomyxoma is a slow growing tumor. It exclusively involves the pelvis and the perineum, and it is usually sizable at presentation, more than 10 centimeter in size. It has the tendency to displace rather than to infiltrate the adjacent structures. On ultrasound, it is hypoechoic or appear cystic. On MRI, it is of low signal in the T1, and in the T2 weighted image, it has a very characteristic appearance due to the myxomatous content of the tumor, which will show high signal intensity. And contrast enhancement is variable, and it is related to the fibrovascular stroma within the tumor. And this is an example of the female patient, 20 years old, with a big mass infiltrating the pelvis, compressing and displacing the urinary bladder and the rectum. And you see the striated appearance or the characteristic sword appearance. And this is the sagittal image. And you can see how big the tumor invading or infiltrating the pelvis, extending very high up in the abdomen. Then this is the T1 fat set with contrast, and you see minor vascularity within the lesion. Another case, and you see a big lesion involving the left side of the pelvis, and the T2 weighted image, you see the characteristic appearance, and after contrast injection, and you see some contrast enhancement. And the differential diagnosis of aggressive angiomyxoma may include lipoma, and lipoma will show high signal in the T1, and it will show fat suppression on fat suppressed images, and is not vascular. Myxoid peripheral nerve sheath tumor is usually symmetrically arranged within the pelvis. Pelvic fibromatosis are large masses of low signal in the T1 and the T2 weighted images because of the fibrous tissue. Angiomyofibroblastoma are tumors of a small size and usually involve the superficial part of the vulva. Mixed mesodermal tumors, malignant fibrous histiocytoma is of low signal in the T1, high signal in the T2, and may enhance with contrast, but the characteristic swirling is not seen in any of these malignant tumors on MRI. And also included in the differential diagnosis is embryonal rhabdomyosarcoma, which is seen in pediatric age, squamous cell carcinoma, which is quite different from this, extramucosal anal adenocarcinoma, which is located in an area where the anal glands are present. And this is once more another example of aggressive angiomyxoma showing in the T1 weighted image, it has no characteristic appearance, but in the T2 weighted image, and you can see this very pathognomonic, let us say that, appearance, and this is after contrast injection with suppression of the fat. And this is also another example of aggressive angiomyxoma. And you go to the CT weighted image where the characteristic appearance will be seen, but on the CT weighted images you cannot appreciate the type of the tumor, and also in other images, and this is the gross picture of the tumor. Then we came to another lesion which occur in the anal canal, which is the verrucous carcinoma or condyloma acuminata. This lesion is intimately related to the human papillomavirus, which is a viral infection transmitted through the skin, and there are over 100 varieties of the virus. More than 40 of them are passed through the sexual contact and can affect the genitalia, the mouth, or the throat. Then this tumor is a large size tumor, locally aggressive with a cauliflower appearance. And giant condylomas are slowly growing and locally aggressive. The distant metastases are rare, but this lesion is strongly associated with human papillomavirus and is also commonly seen in patients with AIDS. Then the giant condyloma acuminatum may have malignant rate of transformation as high up as 50% and recurrence rate as high as 65%. Then the disease can be easily diagnosed by inspection, but the value of imaging, especially the MRI, is to evaluate the deep extent of the tumor and the relation to the adjacent organs. Then this is an example of verrucous carcinoma. And you see the infiltrative nature of the genitalia as well as the upper part of the posterior thigh and the gluteal region. This is the appearance of the tumor. It may be mistaken for lymphoma. Lymphoma can do this, but the gross appearance of the lesion is quite pathognomonic. And then whenever you use the PET-CT, and you got significant metabolic activity in the tumor. And this is another lesion where you see a cauliflower mass infiltrating the perianal area. The CT can show the lobulated appearance, the size of the mass, and also the internal vascularity of the tumor. And this is one of the huge verruca carcinoma type, where you got a very big mass infiltrating the perianal area and then the gluteal and also the root of the penis, and it extends deep in the pelvis, as you can see in this sagittal CT scan post contrast. And also you can see the extent of the tumor on the PET scan. Then, according to the literature, they said that no adjuvant chemo or radiotherapy or curative treatment were administered, as they would not have increased the survival and would have caused serious side effects. Then we came to the anal adenocarcinoma, and adenocarcinoma of the anal canal is in the range of 10% of the anal tumors, and the adenocarcinoma may arise from the anal glands, but most of the anal adenocarcinomas are the result of distal spread of rectal adenocarcinoma. And because of the presence of mucin in the tumor, it will show significant high signal intensity on T2 weighted images. Actually, most of the anal tumors or malignant lesions are treated by total abdominoperineal resection with permanent colostomy. Then radiotherapy or combined radio and chemotherapy may be used preoperative to downstage the tumor. This is an axial and sagittal T2 weighted images showing a mass in the anal area, and this mass is bordered by the external anal sphincter, which looks to be intact, and the mass showed heterogeneous post-contrast enhancement, and the high signal intensity in the T2 weighted image is the sign of this tumor to be of the adenocarcinoma type. Another example, and you see a high signal cauliflower mass in the anal area, reaching the anal verge and extending deep to the lower part of the rectum, indicating that this is a mucinous adenocarcinoma. And you remember in the previous lecture that in long-standing perianal fistula, usually due to Crohn's disease, the patient may develop a carcinoma on top of the fistula, and this is considered rare. But this is an example of adenocarcinoma developing in the anal canal on top of a chronic long-standing fistula. Then we have the melanoma, and the melanoma is rare in the anal region, and the incidence is about 1.5% of all anorectal malignancies. It accounts for 10%. Anal melanoma accounts for 2% of all melanomas, and seen in elderly, and frequently they are misdiagnosed as thrombosed hemorrhoids. We have two types of melanomas depending on the melanin content. The melanocytic melanoma will show high signal in the T1 and T2 weighted image because of the melanin The amelanotic melanoma will show low signal in T1 and high signal in T2, similar to any other tumor. The enhancement is usually homogeneous, and the treatment is usually by surgery. Then in this case, you see a big mass infiltrating the anal canal and maybe the lower rectum, and it is not discriminable from the anal cancer. But as you see here, they said that if you see that the tumor has an area of high signal in the T1 weighted image, and this could be due to melanin. You may suspect the possibility, but you know that many of these tumors may bleed either before biopsy or after biopsy, and the bleeding will have the similar appearance. Of course, anal melanoma will be diagnosed by biopsy, but this patient had a recurrent anorectal melanoma 5 years after resection of the primary tumor, and you got a posterior wall mass with some high signal intensity in the T1, and this is the T2 weighted image in the sagittal view, and this is the PET-CT showing high metabolic activity. And here we can see another example of anal melanoma that is not discriminated from anal polyp, anal granular cell tumor, for example, and many of these lesions. But this arrow points to a pathologically enlarged lymph node here, and the lesion was confirmed by surgery. Then we came to the lymphoma, and the lymphoma of the GI. The GI is considered the most common extranodal site for non-Hodgkin lymphoma, and the most common site are the stomach and the small bowel. Then comes the large bowel. The colorectal lymphoma accounts for 15% of all GI tumors and, of course, of the B-cell non-Hodgkin type. The primary anorectal lymphoma is rare, and it accounts for about 3% of all GI lymphomas, and it may have an intimate relation with AIDS infection. Then lymphoma will appear as a solid mass. It will show mostly a homogeneous signal and homogeneous density with somewhat contrast enhancement. It has no tendency to obstruct the lumen of the bowel, and the presence of ulcerations or areas of breakdown is considered an uncommon features of the lymphoma. And then if you use the PET-CT, you got significant metabolic activity. This is a mass in the anal canal and is associated with bulky, homogeneously enhanced abdominal lymph nodes. And you remember that the presence of lymphadenopathy in association with a mass anywhere in the body, if the nodes can fulfill the criteria of lymphoma, you can consider this mass as lymphoma. And you remember that the criteria of lymphoma in the nodes are the bulky appearance, the amalgamated type, the homogeneous density, the absence of necrosis and calcification. And this is a big cauliflower mass involving the anal canal and extending into the lower rectum. And this is the mass after excision. It has been proved to be a non-Hodgkin lymphoma. And another patient with a mass in relation to the anal canal. And this lesion was suspected to be an abscess and was drained twice with no improvement. And the MRI showed a big lesion in the perineal area and also in the lower pelvis. And this is T2 weighted image, and you can see that this tumor is quite different from the aggressive angiomyxoma. And here you see the intermediate signal of the lesion. If you inject lymphoma, this is another patient. If you inject lymphoma with contrast, and you got minor homogeneous enhancement with no evidence of areas of breakdown. Then we came to the Paget disease, which is considered a skin disease affecting the skin of the breast, and sometimes it may affect the skin around the anal canal. And perianal Paget is an intraepithelial adenocarcinoma and is associated with colorectal and anal cancer in about 55% of the patients. It may present by non-specific symptoms such as pain, bleeding, or itching. The treatment of choice is wide local excision, and if the lesion is invasive, you may consider abdominoperineal resection. Invasive disease can show or can present by metastasis, and the role of imaging here is to detect the depth of the tumor invasion. If you use PET-CT, it will show significant metabolic activity. But as I have mentioned before, this may be considered as a skin disease and is diagnosed by inspection and by having a biopsy from this lesion, but rarely you may need the help of imaging to see the invasion of the deep structures like the anal sphincters, for example, before doing surgery. Gastrointestinal stromal tumor or GEST is also rare in the anal area, and it accounts for 0.2% of all GEST tumors. The patients may present by local disease due to compression, for example, and less than 20% of the patients may have distant metastasis. You remember, guests from the lecture of the rectum is a bulboid lesion, which is a smoothly marginated extraluminal mass. In contrast to the rectal cancer, which is a circumferential lesion with irregular infiltrative margin. The enhancement pattern is related to the size of the tumor. If the tumor is sizable, it will contain areas of necrosis, but if it is small, it will show homogeneous enhancement and is treated by abdominoperineal resection. You remember that these tumors may respond well to some chemotherapy in order to downstage the tumor size, then they may have optimal outcome or favorable outcome of surgery. And here is an example of gastrointestinal stromal tumor in the anal area with minute areas of breaking down because the tumor is sizable, as you can see. Another example of a big bulboid lesion in the anal area with a smooth surface and almost homogeneous signal intensity. And this is also another example of a bulboid lesion in the anal region, and you see the significant post-contrast enhancement. And this is a GEST tumor and a follow-up 4 weeks after chemotherapy, and you got significant regression or reduction in the size, which will help the surgeon and may provide some favorable outcome. Then we came to the rhabdomyosarcoma, which is a tumor of the pediatric age group, and they can rhabdomyosarcoma in this area may represent, or rhabdomyosarcoma in general represents about 4% of childhood malignancies, and the rhabdomyosarcoma in the perianal area is considered very rare. Rhabdomyosarcoma with regional lymph node metastasis at presentation indicates poor prognosis. And you remember that rhabdomyosarcoma may have four histologic types: the embryological type, the alveolar type, the botryoid type, and the pleomorphic type. The most common type is the embryonal type anywhere in the body, but the alveolar type is common in the anal area. Then the imaging modalities are needed here because the tumor is one of the sizable lesions that infiltrate the surrounding areas. It usually appears as well-defined perianal mass and may be misdiagnosed as condyloma acunimata, but actually the condyloma have a surface which is very characteristic. Fibroma and fibrosarcoma. Fine needle aspiration is one of the policies to reach the diagnosis, and also immunohistochemistry is very important in excluding rhabdomyosarcoma from other round cell tumors. This embryonal rhabdomyosarcoma responds well to the chemotherapy, as you can see in the coming cases. And here is an example of infiltrating mass in the perianal area, and the mass is associated with multiple lymph node deposits. And you see this one in the inguinal external iliac and deep in the pelvis. And you remember that the lymph nodes at the time of presentation carries a poor prognosis. And this is a young female, 15 years old, with a big mass infiltrating the perianal area, and this is the diffusion weighted image, which shows diffusion restriction. And here is the appearance of the lesion after injection of contrast, and you can see the heterogeneous enhancement of the contrast. The follow-up after chemotherapy, and you can see, compare this by this, there is marked regression of the tumor. Then the last issue in the neoplasms is the secondary tumors, by which we mean metastasis to the anal canal. Actually, the most common is the local extension from the adjacent malignancies, like especially the lower third rectal cancer, which can spread to the anal area. But other malignancies like stage 4 cervical cancer may invade the adjacent organs like the urinary bladder, anal canal, and the rectum. Also, we have primary malignancies that can invade the anal canal, like the cervix and the prostate, or distant metastasis coming from the musculoskeletal system or the chest. And this is an example of a patient with lung cancer, and there is a mass in the ischioanal fossa intimately related to the anal canal, and it shows intermediate signal and the T2 weighted image, and after in the T2 with fat suppression, and you can see significant increase in the signal of the tumor, and this was a metastatic lung cancer. This patient also had a lung cancer that was treated by pneumonectomy and is proved to be adenocarcinoma, and it presented 3 months later by a perianal abscess and mass, and this is the mass that has been proved to be metastatic from the lung cancer. Also, you may got an advanced rectal carcinoma that extend into the anal canal, and this is seen in the clinical practice, and I have mentioned it in the lecture of rectal cancer, and you can see the extent of the rectal cancer into the anal canal. And this is also an example of lower rectal cancer that has extended to invade the external anal sphincter on the right side. This is the, remember, this is the internal anal sphincter, and this is the external anal sphincter on the left side, which are intact. And the external anal sphincter is involved. And finally, we have two remaining issues, which are the hemorrhoids and the solitary rectal ulcer syndrome. Hemorrhoids are swollen veins located around the anal canal and the lower rectum, and 50% of the patients may have symptoms of hemorrhoid by the age of 50 years of age. And then the hemorrhoids can be internal in the anus or rectum, can be external, projecting outside the anal canal. It may cause pain, severe itching, and difficult sitting. The possible factors for the development of hemorrhoids include straining during bowel movement, chronic constipation, standing or sitting for long periods of time, family history, genetically transformed, consistent heavy lifting, chronic diarrhea, and pregnancy. Then we have 4 degrees of hemorrhoids. The first degree is no prolapse, just prominent blood vessels above the level of the dentate line. Then the second degree is some prolapse upon straining, but spontaneously reduced. The third degree prolapse upon straining down and requires manual reduction. The fourth degree prolapse and cannot be manually reduced. There are some complications of hemorrhoids, and these complications are rare, including strangulation, as if the arteries supplying fresh blood to the hemorrhoids may become blocked or thrombosed, and this may cause extremely intense, unbearable pain. Then anemia may result from too much blood loss. Prolapse, the hemorrhoids may prolapse and cause pain and discomfort. Blood clots and infection. Then infection needs serious management or intensive management because of the serious complications. Then the management of hemorrhoids is usually, especially the third and fourth degrees, is usually by surgery. And the procedure is known as BBH, which indicates procedure for prolapsed hemorrhoids. And this procedure may have complications. The first is proctitis and rectal edema. And rectal edema and proctitis are seen in about 11% of the cases. Then this may present by pruritus or blood and mucus in stools. Other causes of proctitis should be excluded, like inflammatory bowel disease and fecal impaction. So the pathophysiology of proctitis after hemorrhoidal surgery is not clear. 90% of proctitis following hemorrhoid surgery is diagnosed in patients managed for third-degree hemorrhoids. And actually, those are the candidates for surgery. If by any way a biopsy was taken, it may result in serious bleeding and infection complications. Then this is mucosal edema after hemorrhoidal surgery, and there is no signs of perforation. And this is considered the moderate degree of mucosal edema of the rectum with no evidence of perforation. And this is a severe degree of submucosal edema with congestion and dilated vessels, as well as fluid that has been proved on surgery to be pus. Then the second complication is bleeding, and minor bleeding is expected in any anorectal surgery. Major bleeding is rare, and the hemorrhoidectomy has higher rates of bleeding compared to other anorectal procedures. About 24% of patients with bleeding after hemorrhoid surgery will go back to the operating room for another intervention. Then the patients who are at risk of bleeding are those on hemodialysis and those who are receiving anticoagulant therapy. And here is an example of bleeding after hemorrhoid surgery, and you see the extravasated blood in the distal part of the rectum, while the rectum is distended by hemorrhage. And this is an important issue whenever you are going to assess patients with suspected hemorrhoid complications, and you should go by the scan up to the end of the pelvis, and even you go into the groin in order to cover the area of suspicion. And this is another rectal bleeding after a hemorrhoid surgery. You see the blood filling most of the rectal cavity. And this is also a bleeding after hemorrhoid surgery. You got the bleeder with active extravasation of injected contrast material and big hematoma in the rectum. And these lesions may be treated by intervention, where you go by a catheter, then you inject the superior hemorrhoidal artery and you see the bleeder, and you go by microcatheters to embolize or occlude this bleeder. Infection is also a complication of anorectal surgery, but it is uncommon according to the literature. And the presence of swelling and some pain are expected after most of anorectal procedures. The diagnosis of infection may be difficult and may be delayed because of this. And there are three important warning signs of infection that are fever, worsening pain after initial improvement, and development of delayed urinary retention. These are the signs that you should suspect the presence of infection. Actually, MRI and CT have a major role in the diagnosis of this particular complication, and to see the extent of abscesses and the site of pus collection. And this is the staples of hemorrhoid surgery, and you got collection with air loculi inside the collection, denoting the presence of pelvic sepsis. Then one of the serious complications, or even a life-threatening complication, is rectal perforation. And rectal perforation may require temporary or even permanent colostomy. And the perforation is usually above the staple line of the hemorrhoid surgery. And the possible causes are Either the peritoneum has a low reflection that has been incorrectly incorporated in the suture, or the suture is placed relatively too high to incorporate the peritoneal reflection. Some patients are more prone for this, those who have enterocele or the low position of the Douglas pouch, as in cases of previous hysterectomy. The dehiscence of the stable line is the common cause of rectal perforation, but the cause of this dehiscence is unclear. The stable line dehiscence is often accompanied by extensive hemorrhage, but the presence of pneumorectoretroperitoneum is extremely rare. And if you see air loculi, then this is the localized site of perforation. Actually, you may think that this is secondary to an infection and the presence of abscess formation, and this should be guarded carefully to assess the possibility of perforation. But this is a clear evidence of perforation after hemorrhoid surgery, and you got extensive air in the retroperitoneum and intraperitoneal 2 days after surgery. Then urine retention is also one of the complications of hemorrhoid surgery, and is considered the most common complication after anorectal surgery, seen in about 15% of the cases. And there are some risk factors. Then the factors are not modifiable, like the age, the sex, and the type of surgery. Also, epidural and spinal anesthesia, as well as the introduction of excess intravenous fluids, increase the risk of urine retention. The symptoms include pain, pressure, unproductive urge to urinate, frequent small volume of micturition, with persistent feeling of incomplete evacuation. Urine retention, of course, can lead to urinary tract infection. And there are some of the other complications like thrombosed hemorrhoids, which will result in significant pain like this appearance. Severe constipation is common after anorectal surgery, mainly because of the patient is afraid of pain. Then hemorrhoidectomy has the highest rate of severe constipation. Anal fistula may be reported. Rectovaginal and anovaginal fistulae may be also reported. And finally, this complication is anal stricture and stenosis. And if you exclude coloanal anastomosis, anal stricture and stenosis are most commonly seen after hemorrhoidectomy. And patients with anal stenosis will report straining to have bowel movements, small caliber stools, and pain with defecation. Stenosis may lead to fecal impaction and overflow incontinence. It can be assessed by digital examination, anoscopy, and proctoscopy. But in cases of tight stenosis and severe pain, you may need examination under general anesthesia. And finally, we came to what is known as solitary rectal ulcer syndrome. This is an uncommon benign disorder of defecation, and it is not necessarily an ulcer and may not be solitary. Then the diagnosis of this lesion is based on endoscopy, where you see a large, well demarcated ulcer, or a cauliflower looking tumor, or edematous swelling of the mucosa. Then This ulcer may affect different parts of the rectum and other sites of the gastrointestinal tract. The cause is unclear and may be related to rectal prolapse or severe constipation. The symptoms include rectal bleeding, tenesmus, mucoid secretions, rectal pain, and about 50% of the 25% of the patients are asymptomatic. The main diagnosis is by direct colonoscopy and histopathological study of the lesion. The solitary rectal ulcer syndrome ulcer may be confused with inflammatory bowel disease and the neoplasms. Actually, the role of imaging here is extremely limited because when you see this lesion, which is bright in the T2 weighted image, and according to the literature, they said that this is classic for mucosal infolding or mucosal polyps, and I don't think so, in my opinion, but this is just an example of the appearance in the MRI. And also, they said that by barium study, you may see some prominent mucosa, some ulcerations, and infolding of the mucosa. And this is not common because you may not see this subtle changes in the rectum, and the diagnosis is mainly based on the endoscopic evaluation. And this is another example, and it was diagnosed as solitary rectal ulcer syndrome with non-uniform mucosal thickening of the rectum, as you can see, and the significant metabolic activity on PET-CT. And this lesion was diagnosed as solitary rectal ulcer syndrome. And you see the appearance by endoscopy is relatively pathognomonic to this lesion. And also the endoscopic ultrasound can help in the diagnosis of solitary rectal ulcer syndrome, and there are some of the mentioned criteria, including that there is considerable thickening of the submucosa, and you compare it, this is the normal appearance, this is the submucosa, and here you can see the thickening of the submucosa, and also the thickening of the muscularis propria area compared to this. And also you can see that there is a relatively echogenic band between the layers of the muscularis propria. And according to the literature, they said that if this is an infiltrative pathology like infection or neoplasm, this line would not be present, because this line indicates that you are dealing with a non-infiltrative pathology. This is according to the literature, and the diagnosis of solitary rectal ulcer syndrome in this particular case was confirmed by histopathologic examination. Thank you very much.